endoscopic spine surgery on a patient with a painful disc at L5-S1, I believe, correct?
Yes, sir.
Yeah. Now our patient has more than one herniation in his back, but we're doing just the one today by choice by the patient. I think he's got 2 discs that are painful, but we're doing just the L5-S1 today. This is again by patient's choice, not mine. Now our patient has COPD, so he's going to be as minimally sedated as we can make him. We don't want to have him obstruct his airway in any way, so I'm going to be using a lot of local and trying to keep him comfortable without putting him deeply sedated. Very good. All right, we're going to get started. Can you hear me? All right, Dr. Duke here. We're going to get started. I'm going to be giving you some numbing medicine, okay? All right, you just relax. If you feel any pain, say ouch, and I'll give you some more numbing medicine, okay? All right, right now I'm just feeling around. I'm feeling my landmarks on the spine. I'm feeling the iliac crest. Our patient is pretty debilitated with pain. You're going to feel a little stick and burn, okay? All right. Now, I can't tell you exactly where we need to go in because it's very hard to do that. You can't look at somebody's back and see where the discs are. Sorry about that. That's that numbing medicine. I apologize. Yeah, no, it's going in, it's uncomfortable, but once it starts working, it'll feel better. Yeah, I'm sorry about that. Nothing I can do about it, unfortunately. All right, we put in about 5 cc's. All right, so we have to use an x-ray machine to find the parts of the spine to fix during surgery. There's no other way. There's x-rays are always used, whether it's a CAT scan or an x-ray machine. CAT scans use x-rays, and they just reconstruct the x-ray images 3-dimensionally to give you a little bit better picture, but we don't need a CAT scan to do these types of surgery, but we do need an x-ray machine. All right, try to lay still, okay? I'll do my best to make you comfortable. Shot? So we're going to use this x-ray machine and navigate. Really, Jordan? We're pretty low. I think we're going to need to go a little bit higher. Let's see. Yeah. Yeah, we need more local. You're going to feel a little more numbing medicine go in. I apologize. Is that better? A little bit? All right. Do a little biofeedback for you. All right. We have to use a little more of the numbing medicine in the skin and stuff because we can't sedate you as much. I talked to your cardiologist. Where's our blood pressure? 148. Anything we can do to bring it down? Yeah. I'd love to get it around 110. All right, shot. So we can see that he's had kyphoplasties before for problems with his spine. He's had fractures. That's better. And I didn't do the kyphoplasty. Somebody else did. Shot? Yep. Need to start a little bit higher. Yep. Are you feeling any of that? Is that better?
How are you doing?
Trying to make him as comfortable as... Don't put your hand like that when I'm bringing a sharp bit. You're going to get stuck. That will be bad. All right, so we're trying to find the right entry point for him, and you have to take into consideration the iliac crest. And his anatomy is a little bit unusual because he's been so deconditioned. Is that it? Let's go lateral. And we're going to have to do a little better on the AP view. You're pretty close. The spinous process is almost centered, but I like to get a little bit better centering. So because he's so deconditioned, he spends most of his time, I think, in wheelchair bound. He doesn't get a lot of activity. You can see the osteoporosis. The bones are just not strongly developed on the imaging, and that's because basically the bones are very thin. All right, so that's pretty good. I'm trying to get to 5-1. Let's get that pedicle lined up a little bit better. I think it's not terrible, but let's see if we can make it a little bit better with some wagging. No, it's worse. Let's move the floral base south a little bit. What can you do there, Jordan? I don't think we're too far off. See if we can get those pedicles lined up just a little bit better. Shot. I think that went maybe the wrong way. Let's try the other way. It's not a wag, it's a rotation. So right now I'm using the X-ray machine to basically line the spine up appropriately so I can access the L5-S1 disc. I think that's probably as good as we're going to get it. Shot. 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 Let's get an AP view. That's good. That's a good lateral, by the way. We've got that. I think we're a little bit off, but he's got bad scoliosis anyway. It's not going to be possible to get it perfect. Just got to get around this facet joint. That looks good. Let's go back to a lateral view, please. All right, so if you're watching the surgery today, you're watching a live broadcast. Duke Spine Institute broadcasts its surgeries live over the internet for people to watch in real time. We do that so you can be part of the surgery and you could ask questions as well. Shot. All right, once again, our patient is awake at this point and hopefully comfortable. Shot. I think I'm bumping up against this facet, but we're pretty close to getting around it. I know that's a little uncomfortable. Shot. Are you doing okay?
Stuart, are you doing okay? Good.
Okay. He's got a lot of arthritis here. I can feel. Shot. And that's not in the disc, it's in the facet joints behind the disc. Shot. 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 And I'm trying to navigate around that arthritis. Shot. Shot. Very close. Shot. 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 It's hitting the iliac crest. Shot. Where do you feel that? Shot. Huh? All right, everything's okay. Shot. Yeah, I know that's a little uncomfortable. I apologize. Shot. Unfortunately, we're a little limited in how much we can put you to sleep during this because of your COPD. Shot. So we don't want to overdo it. Shot. Shot. What's he saying? Yeah. We're so close. Just so much arthritis here. Yeah. Shot. Shot. Just really bumping up against his iliac crest. That's the problem. Right now. So there's a very narrow window to get in, and it's limited by the iliac crest superficially in the facet joint deep. Let's see what we can do on this x-ray. Let's try to wag the x-ray a little bit, see if that improves the picture. I don't know if he's moved a little. Let's go ahead and wag it a little bit, just like 1 degree, and get a shot. See if that makes it better or worse. Actually, it looks better to me. Let's keep it there. Shot. Shot. It's perfect trajectory, except that facet is just blocking me. Shot. Shot. Where do you feel that? Where do you feel it? Huh? But not down the leg. Shot. Let's get an AP. Hang in there. You're doing really good. You're doing a great job. Unfortunately, it's even harder for you because we can't put you to sleep. Normally, we can give patients some sedation during this part. But with your COPD, I just don't want to take any chances. That looks good. Let's go lateral. Yeah, it's more important that you're healthy and you come out of the surgery, at least from a pulmonary and cardiovascular standpoint, the same. All right. Where do you feel that? Huh? Is that, are you comfortable? What do you say? But now it's okay? All right. All right, so just for those of you watching, we're looking at a side view x-ray. All that dark material at the upper half of the x-ray is cement, medical cement. It was put into a spine. I did not do that, someone else did. That was done for fractures of the bones. And, huh? Did he say something? Oh. And, you know, it's a very common technique. It's done all over the world. It's called kyphoplasty. There's vertebroplasty is another name for a little different technique. But the point is, when you fill a bone that's fracturing with cement, medical cement, which is polymethyl methacrylate, then it actually supports the bone and stops it from fracturing. So the pain goes away. And what's wrong?
Oh, you just put it on your throat?
Oh, okay. All right, so we're going to introduce another substance that's dark into the disc, but it's not the same as a cement, so it's just a dye. Are you comfortable? You feel anything? Huh?
Yes, it hurts back there.
Oh. How bad did it hurt on a scale of 1 to 10? What's the worst it got?
8.
8? Is that where you typically get pain?
Yes.
Yeah. Concordant 8 over 10, L5-S1. I think he's going to need L4-5 done too, but he only wanted to do one level today. So we're going to get some of his pain gone. You can keep him awake, and this is where we're just going to have to figure it out, right? All right, let us know if it's uncomfortable for you, okay? You might feel a little discomfort. That's normal. Shot. So what I've done, folks, is I've injected into L5-S1 some dye, which you visualized on a lateral x-ray. There's really not a big tear, so I think mostly what we're dealing with is a condition called internal disc disruption, IDD. It's not common, but it's a condition where you don't really have a big tear, but the inside of the disc has been damaged and kind of partially healed itself, but it's still painful. We're going to make our incision. So it's a 7mm incision. Now, this is going to be the more stimulating part. So what I'd like to do is, we have the, and do we have a needle? A what? I think that, what about the 22? Oh wait, no, the 18's okay. I'm going to numb things up a little bit as I go in. It's a little different than we normally do, but should be fine. Are you comfortable? Yeah, I'm giving you some numbing medicine as I'm doing this, but I don't want to put any down by your nerve, otherwise you're going to have some weakness, which will be from the medicine itself. Maybe numbness. Shot? Just let me know if it gets really uncomfortable for you, okay? Can you hear me? All right. We're making our way down to the foramen. I'll give him, let me see where we are, Shot. I can give him a little more medicine right now, just a little bit. Put the needle on. I've injected another 2 cc's. And this is, what is this, Luis? Shot? All right. What percent bupivacaine? 2%? And the lidocaine is what, 1%? Half percent? What? Oh, lidocaine, then what's the bupivacaine? Oh, 0.5%, okay. All right, so we're just outside the neuroforamen where the nerve is. We're just passing the facet joint. I put some more numbing medicine there to numb the things up so it's not too uncomfortable for him. Are you okay? Shot. All right. Shot. Okay, so I need the impactor. No. Shot. He's comfortable? Shot? Yeah, here's where we get to the annulus. This is the part that will be the most uncomfortable for him. Yeah, I know. Shot? Yeah, hang in there. We're almost done. Shot? This is that bad disc of yours. Yep. Bear with me. I need the mallet. Almost done. All right. Okay, you know what? I may be able to put a little in the disc, but it's going to leak out around the root. That's the only problem. So, okay. This is our tubular retractor. We're going to do the whole surgery through this. Heart's doing good. Just, yeah, I know. If you're going to give him anything, this would probably be the time to give him a little whiff of something. I know propofol doesn't give any pain relief. Just relax, everything's okay. You want me to wait a minute? You're doing fine, it's okay, we're in that bad disc. It's going to feel a lot better when we're done. Yeah. Let me know when I should proceed. You're doing fine. Everything's okay, I promise. So, I'm sure he'll watch his surgery someday, but we know this disc was an 8 out of 10. Concordant, meaning it's his typical pain he gets every day. We just need to advance the tube into the disc. And once we've done that, we can get started on the surgery. Should I advance? All right, so we're trying to minimize the amount of sedation he's getting to just the bare minimum. Let's see. Shot? Yeah, that's perfect. And that way he doesn't stop breathing. Fluoro out. Should be done in about 10 minutes. Let's go. You can see the marker on the tube. That tells me where the opening is. All right. This part won't be as painful for him right now, but once I get closer to the outer annulus, it will get more painful. Okay, scope is on. We are inside the disc. Let's get the laser going. No, it's this hand. Okay. That's the disc right there. Let's have the grabber and the laser. Grabber first, then the laser. Come on, quick. Get your cotton ready, your Raytech. See if I can grab any of this herniation out. Yeah, there's a piece. You got one swipe. There's not a lot of time. Oh. Here's another little piece. Take it. Give me the laser. All right, we need the laser on. Our laser is a medical grade Holmium YAG laser. I will only use a Holmium YAG laser, and it's of course a medical grade laser. In the United States, there are lasers that are specifically manufactured and produced just for medical purposes. Right there is a little bit of pink. We just zapped it. There's a lot of scar tissue in here. Remember I told you internal disc disruption? This is what it looks like. All this is scar tissue inside the disc. Why would there be scar tissue in the disc? There's only one way to get scar tissue, folks. Anybody know what it is? Let's see if our audience knows. Do 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 do. All right, Sonny. Any takers?
No takers.
No takers. The reason you get scar tissue is inflammation. That's the only way to get scar tissue in the human body, through inflammation, the inflammatory healing process. So, this disc is full of scar tissue. I can tell you that. I see it. Time out. Let's see, hold the scope. Wipe the tip. It's full of bubbles. Can't really see that well. So basically, why are there still bubbles there? Wipe the surface. Don't just wipe the ends of the tube. That's better. See, now they're gone. You done good, boy. Cam is here helping me today. Luis is running the laser. And we have a wonderful anesthesiologist who's helping us. We were actually supposed to do a posterior cervical decompression infusion this morning, but unfortunately it got canceled because the patient apparently had an issue that required us to postpone something regarding the blood, their blood needing a transfusion. But this patient was next on the docket, so we just moved him up. So for those of you expecting to see a fusion, I apologize. It's not my fault. I came ready. But the patient that was supposed to have the fusion had a medical issue that we had to postpone the surgery for. All right, this is all scar tissue. This is a piece of herniation just scarred in there. So this, what I was getting at earlier is there's scar tissue here in the disc when there shouldn't be, and it's because there's tremendous amount of inflammation in the disc. This patient's had back pain for a long time. And like I said, he's got fractures that have already been dealt with kyphoplasty, not by me. And the reason I don't do kyphoplasties, I used to do them many years ago. It was just too simple of a procedure for me to spend my time doing. I do the more complicated surgery procedures. And Dr. Patel, I trained Dr. Patel how to do the kyphoplasties, so he's the one who does them at Duke Spine. And honestly, he does an amazing job, better than most surgeons. And he is an interventionalist, so he does phenomenal kyphoplasty. Probably, honestly, better than me at this point. He's been doing them for years. And I've stopped doing them about 5 years ago, after I trained him and supervised him and made sure that he knew what he was doing. Okay, we're going to start pulling our cannula back. There's the end plate, and we're inside that L5-S1 disc. There's a little epidural fat, beautiful. We'll be done in 5 minutes, I'm hoping. Why does the irrigation look compromised? Is it flowing? No, it is. I guess there's just a lot of debris from the laser. Again, tremendous amount of scarring here, indicating that there's been inflammation here inside this disc going on for a long time. All right. Any questions from the audience, Sonny?
Not at the moment.
Great. Our audience knows, they know more than me. They don't have any questions. So this surgery you're watching is the most state-of-the-art spine surgery in the world. 95% of spine surgeons in the world that would treat this painful L5-S1 disc would do a fusion. Maybe 5% of them would do an artificial disc. Patient has osteoporosis, so it's pretty much not a good choice for either of those surgeries. The surgery you're watching is a more advanced surgery than fusion and artificial disc. It's the next level of treatment. Unfortunately, not many surgeons know how to do it in 2020, since we're in the year 2020. Someday, this is going to be the standard of care for all herniated discs in the neck, the back, the thoracic. This is what surgeons will be doing. We're already doing this at Duke Spine Institute. We are the pioneers. We're the first to do it. Now, we're not the first to do endoscopic surgery in the lower back. We're not the first to do anterior cervical endoscopic surgery, but we're the first to do what's called an annular debridement, which is where we go in and clean up the annular tear in order to treat pain. The pain in the back, the pain in the neck. Most surgeons don't treat pain, okay? Spine surgeons don't treat pain. They don't believe surgery works. That's because all they have is more primitive types of surgery like fusions, laminectomies, discectomy, and now artificial disc. But those surgeries are very bad at treating pain from a disc. This surgery you're watching, the whole purpose of the surgery is to treat pain from a disc. Because what I'm doing is something that no other surgeon does. I'm cleaning up the annular tear with the laser so it can heal properly and heal painlessly. In other words, it's the tear here that causes the back pain. And the fact that the tear is trying to heal but cannot heal. And it cannot heal because there's nucleus pulposus wedged in to the annular tear, causing inflammation and pain. So the pain is a result of the inflammation. The inflammation is a result of, I need just 3 minutes probably. The inflammation is a result of the tear and the nucleus pulposus that's stuck inside the tear, and the tear is trying to heal but it can't because the nucleus pulposus is there. It's kind of like having a splinter in your finger. Your finger is trying to heal but it can't because there's a foreign body, a splinter there, a piece of wood or metal. Stand by. And the body still tries to heal even though there's that, your body keeps trying to heal even though there's a foreign body, a splinter, a piece of wood, stuck inside it. So it keeps trying to heal, and it creates inflammation. It's attacking the splinter with an inflammatory response. And that's painful because inflammation is painful. Every doctor knows that. You know, think about what a pimple is on your face. That's an inflammation. And imagine that being in your disc, in your back. And every time you bend, twist, carry something, you're putting pressure on the pimple in the back of your disc. That's what we discovered at Duke Spine Institute, and that's why we're able to cure back pain. Because we're the only place in the world you can go to have an annular debridement. And we're the first surgery in the world to do an annular debridement. And all this was published in 2012 in Surgical Neurology International. Just look it up and you can learn about it. All right, that's a little epidural vein bleeding. And we are just about done, probably another minute, and we're done. How's he doing? Good, good, thank you. And then we have another laser surgery coming up next. I think it's a lumbar, right, Louis?
Yes, sir, 2 levels.
2-level lumbar. And that patient will be able to put a little more to sleep, even though this one here is completely comfortable, not responding or anything. So our anesthesiologist has done an amazing job. This is all chunky scar tissue. It's totally abnormal. You never see it this thick unless it's scar tissue. This is not what a normal disc looks like. A normal disc is soft and billowy. And we could probably even see the nerve root up there. That's the end plate, and I think the nerve root's going to be just above this. Right, there it is. There it is. There's the nerve root. You see that? The white right there? That's the nerve root. And that's a little bit of fat around the nerve root in the foramen. So the nerve root's intact. We didn't damage it or anything. There's the herniation. I could zap this fat out of here. But of course I'm going to stir up some bleeding. This fat always has a blood supply. And we just don't want to do too much of that. I just want to mostly get this painful part of the disc out so he can be out of pain at least at L5-S1. All right. We're pretty much done. I just want to clean this real quick. That's the last of the tear right there. So remember when we did the discogram, we didn't get a big tear out to the periphery with the dye, but the tear is there. This is it right here. So what's happened? Well, it's healed. I mean, it's partially healed, right? And so that scar tissue has closed the tear over the years, but it's still a painful tear. That's why we have to come in and debride it. By debriding the painful tear, it should take away his back pain that he had. And if I were to do another discogram tomorrow at this disc, I believe the pain would be completely gone at L5-S1. He would have zero pain. Okay. 30 seconds now. Just don't want to have to come back here again. All done. Laser off. We are done. Gonna suck all the water out. There it is. Scope off. Scope off. Okay. Put a little medicine to give him some relief. You could see the nerve root was not red and inflamed. It was white because it's not a radiculitis. We're not dealing with a leg problem here, like leg pain. We're dealing with back pain. This patient had the surgery for back pain, and his nerve root, his nerve root was fine. Okay, we're not dealing with a leg pain issue, sciatica. We're dealing with back pain. So we're the only center in the world that actually treats back pain and cures back pain because we're the only place that does this surgery.
I have a question.
You have a question, or the audience has a question?
Well, the audience has a question.
Oh,
That's a
because
short
I was
question.
going to say, Sonny, you've been here far too long to have questions. Okay.
No. Yeah.
We'll take the audience question.
The audience had a question about the lack of dye.
The lack of dye?
Yeah.
Oh, during the procedure.
Yeah.
Yeah. So, okay, that's a great question, and I'm glad you noticed that. So remember when we did the discogram? Go back and rewind, and you'll see there's like almost a cotton ball of dye in the middle of the disc, and it really didn't go through a tear to the outside. Well, that's why the tear was white today. It was not blue. It wasn't blue because the dye only stains nucleus pulposus, and to stain the nucleus pulposus that's stuck in the tear, the dye has to reach the nucleus pulposus. So because the tear had partially healed so well with all the scar tissue, that collagen of the scar tissue walled off the nuclear material and preventing it from getting stained. And scar tissue is white. That's why everything appeared white. So basically, the annular tear today was whiter optically to our eyes because very little of the nuclear material stained because the stain did not have access to the nuclear material within the tear because it was so scarred up. So the key is the scarring, the scar tissue. Great question, great observation. All right, here is the incision. The whole surgery was done through this tiny little cut, and our patient will go home in about 30 minutes to 45 minutes. And he was comfortable during the procedure, which is a blessing. Great question, and I'm going to head over and I'll answer any other questions you have. Thank you, everyone. Phenomenal job. Cam, great job today. Was that fun? Yeah, it's pretty amazing. Endoscopic spine surgery. If you would have told me I'd be doing endoscopic spine surgery as a resident at Shands, I wouldn't have believed it. I'm going to call the EBL 2 mil. No complications. Thank you. All right, I'm heading over. Write your questions up, type them up. I'll answer them for you.
Hello there. This is Sonny from Duke Spine Institute, live with Dr. Duke, and we have our first question from Facebook from Julie. What about thoracic pain with radiation of pain around the ribs? A neurosurgeon tells me they cannot help me with my T7 to T9 bulges. She has deliberating pain.
debilitating. Are we on? Okay, folks, Dr. R. Deukmedjian, once again CEO, founder of Duke Spine Institute here in Florida. We're located in near Orlando. And Sonny, thanks for helping. Sonny is actually filling in for Sean. Sean is out on vacation, and Sonny's doing a phenomenal job. I appreciate it. So the question is, well, from one of our viewers, they say, listen, I've got herniated discs, 2 of them, and my neurosurgeon says there's nothing that can be done. What do you think, Dr. Deukmedjian? So you're right, there's nothing your neurosurgeon can do, okay? No doubt about it. Thoracic disc herniations are the hardest things to treat in the spine when it comes to herniated discs. Lumbar and cervical are relatively easy to get to and fix safely and pretty commonly treated. There are about 200,000 anterior cervical discectomy infusion for cervical disc herniation done in the United States every year. There's about probably 400,000 lumbar disc herniation surgeries done in the United States every year. But thoracic disc herniations are much less common, and thoracic disc herniation surgery even rarer. Why? Because several reasons. Why are thoracic disc herniations not common? Well, you have the ribs that support the spine and give extra stability. So thoracic disc herniations are just not common because that part of the spine doesn't move as much. So there's less force on the disc, less chance of trauma to the disc. Julie, hi. Do you know how to make coffee? Thank you. I'll be done in 5 minutes. Julie just came here. Julie is the head of billing, our billing manager. She's wonderful. We have so many projects we work on together because the insurance companies don't want to pay for your medical care, and they'll tell you they'll pay, and then when you get the surgery done, they don't pay. So we're always constantly fighting them to get payment. Getting back to thoracic disc herniation. So the reason why there are very few thoracic disc herniations, just to recapitulate, is that the thoracic spine is extremely stable because of the ribs. So there's not a lot of movement, not a lot of injuries. But when people do get thoracic disc herniations and they cause symptoms, really the first step in treatment should be an epidural injection as long as there's no spinal cord injury or nerve damage. And as long as that's the case, it's just thoracic pain, we always recommend conservative treatment first, therapy time, and maybe some injections and anti-inflammatories. If that fails to work, then surgery is definitely an option. So if you were to take the 3,000 neurosurgeons in the United States and ask them to do a thoracic disc herniation surgery, any surgery they know, only about 5% of them would ever do a thoracic disc herniation surgery. Why is that? Because fixing a thoracic disc herniation has always involved massive, major, difficult, complicated, risky surgery that requires the patient to be admitted to the hospital, ICU after surgery, basically on the brink of life and death for a few days, and then nurse the patient back to hopefully recovery. Why is that? Because getting to a thoracic disc herniation is very, very difficult because the spinal cord, the thoracic spinal cord, sits right behind the herniation, so you cannot get to the herniation through the back. You can't push the spinal cord over to get to the herniation that's in front of the spinal cord. So you have to come from the side. You can't get there through the front either because you have your heart there, your aorta, your lungs. They're all blocking access through the front. So normally with a cervical or neck disc herniation, you go through the front. Sometimes you can even go through the back. But with a lumbar, you can go through the front or the back or the side. But with thoracic, you really can only go through the side. So that requires cutting a rib head out. It requires mobilizing the paraspinous muscles completely off the spine. I mean, literally, it looks like a piece of flank steak when you're done, and you have to flip it over to the side. And then you got to try to get to the disc herniation and put a cage and screws and rods and fuse. Massive surgery. So the good news is Duke Spine Institute and myself have developed a new technique, endoscopic spine surgery of the thoracic spine, in order to repair herniated discs in the thoracic spine. Now, let me just give you a little bit of background. I learned how to do endoscopic spine surgery 15 years ago overseas from the South Korean surgeons that were doing it, from a German surgeon that was doing it, a British surgeon doing it, and an American surgeon over in Phoenix, Arizona. Where are you going? I'm ready. Come on in. And, you know, basically these surgeons all did lumbar spine and transforaminal endoscopic, the kind of stuff you just saw me do. But I did L5-S1 today. They don't do L5-S1. It's too hard for them. So I would do anything in the lumbar spine, and I started to work my way up closer to the thoracic spine over the years with great success and no complications. To date, in 15 years of me doing endoscopic spine surgery, I've had 0 complications, like literally not a single complication from surgery. And I've done over 1,200 surgeries. What does that mean? Well, really what it means is that it's a very, very safe type of surgery to do. And the results in terms of pain relief is better than any surgery in the world. There's no surgery that even comes close. Fusion surgery gives people pain relief 50% of the time. When I do fusion surgery, it's much higher because I do different technique than every other surgeon. But just take the average neurosurgeon that you're talking about, getting rid of the back pain or neck pain with fusion is 50-50, 50% at best. Is the coffee brewing?
Yes.
Huh? Can I get a cup, please?
Yeah, when it's done.
Dump that one out. It's old. So basically what I'm getting at is the existing treatments for neurosurgeons to fix pain from a herniated disc in the lumbar and cervical spine are very poor. They don't work, but the Duke laser disc repair does. We're able to get 95 to 100% pain relief on average, basically, in our patients from that disc with the laser surgery we do. Because I do something no other surgeon in the world does. I repair the annular tear with a laser. And it's actually a debridement that I'm doing to get rid of the pain. So I've done this type of surgery in the neck for the cervical disc herniations and in the back for the lumbar disc herniations, but I had never done it in the thoracic spine. Why? Because A, I was never taught to do it. I mean, at least with the cervical, the Koreans were doing it. Even though nobody else in America does it, I'm the only surgeon in the United States that does anterior cervical endoscopic surgery. And in the world, there's only me and the Koreans and Sebastian Roten in Germany that I know of that do it. That's one surgeon in Europe. So anterior cervical is rarely done because it's so complicated and difficult to do and takes tremendous experience and expertise, and you have to basically know what you're doing, otherwise you could kill the patient very easily. So I spent the last 15 years doing anterior cervical disc surgery, kind of walking the tightrope, but fortunately no complications in at least 500 cases. And now I started to look at the thoracic spine and thoracic disc herniations. And the first patient that I even considered doing, and the answer had always been no when patients ask me about treating a thoracic disc herniation. I'd said no, 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 never done it, don't want to do it, it's too dangerous. But then I had a patient who was absolutely desperate with pain in their thoracic, and there was no other option for them. And they begged me, and I thought about it, and I said, I'll try it. But the first sign that we have a problem, or the first sign that, we're getting close to having a problem, I'm not going to create a complication. I don't want to. I don't want to kill you or paralyze you. But so I did the surgery, and it was this year, 2020, and it went really well. It was a 1-level thoracic disc herniation, and I was able to do the approach transforaminal through the back. I went just medial to the lung and the ribs, and I went just through the paraspinous muscles, just lateral part of the paraspinous muscles, transforaminal. And the patient had 100% relief of their thoracic pain, 100%. And they still do. So then I figured, all right, I did one, I'll try another one, But same thing though, if I get any whiff of trouble, I'm quitting, and I'm going to abort the surgery. So they were fine with that. Again, no other option. And we did the surgery, and this time I had 100% pain relief again. No complication, and it went well. So then I did a third case this year, and it was a 2-level, and it went well. And then another 1-level, and then a 2-level. I've done 6 patients so far this year with thoracic disc herniations, and every one of them has gone very well. I've done skinny patients, I've done large patients, and I've been able to do it without complication, but my number is very small, 6 patients, and with a total of 8 discs. So these are the first in the world ever being done. Nobody in the world has ever done a thoracic disc herniation endoscopically, transforaminally through the back, at a 45-degree angle to the spine axis. So you asked, I gave you the answer. Yes, we can do the surgery at the levels. I think you said T8-9, T9-10. What was it? Yep. T8-9, T9-10 can be done endoscopically if you come to Duke Spine Institute, but you will find it done nowhere else in the world. And we are literally the leaders and pioneers in endoscopic spine surgery. So, any other questions? We have one more question. I'm going to turn the mic over to Sonny. Hopefully I answer that question appropriately. If you're interested, by the way, anybody out there with a herniated disc or stenosis of the spine or pain in their back or neck, thoracic, feel free to upload your MRI. If you have an MRI, upload it. We will review it at Duke Spine Institute as a free service. We don't charge you. We do it for free. We do it whether or not you get treatment. It's not contingent or dependent on treatment. Anybody that wants an opinion about their spine, we're happy to provide it for free. We do this as a community service. It's all just basically us donating our time to help people to understand what's wrong with their spine and what can be done to fix it. And we get people from all over the world submitting their MRIs, all over the world. So I encourage you to check out the Duke Spine Institute app. If you have a phone or computer and you go to the App Store, type in DEUK, Duke Spine Institute, and you'll find the app. It's free. Download it. You could even submit your MRI through the app. All right, here's Sonny for our next question.
All right, second question comes from Magnus on Facebook. He's in Australia and he can't get an MRI. And he asks, is there a way to, other than the obvious pain, to persuade further help where, as you've mentioned before, Dr. Duke, they may not believe you, to encourage more assistance to get to the root cause of the issue before it ends up debilitating?
Hello, Magnus. Unfortunately, Magnus, let me explain it to you this way so you understand it better. There's a show on television that focuses on a problem in the world that has to do with whaling, okay? And I picked this topic not for any connection to you in Australia, but because it highlights the absolute stubbornness and ignorance of people when it comes to certain issues. Well, there's a group of people out there that are whaling the hell out of the oceans and killing all the whales they can and eating them. And there's people who feel this is wrong and understand the whales are endangered species and we need to protect them as human beings. So it's a fundamental difference in belief, and there is no way you will change the whalers' attitudes, and there's no way the whalers will ever change the attitudes of the conservationists who are trying to protect the whales. You understand what I'm saying? So what you're seeing here today in Australia is the same everywhere in the world, including the United States. Doctors don't believe that back pain can be cured, and they've spread this dogma, for lack of a better word, all around the world to people. And the reason is because they don't know how to cure back pain or neck pain or thoracic pain. They just don't. But Duke Spine has figured it out. And we have a series of tests that we do, including a very detailed physical exam, diagnostic blocks done with needle procedures, and it has tremendous amount of expertise and equipment and testing needed to basically figure out where people's pain is coming from. An MRI is just the start. The MRI usually will not tell you where the pain comes from exactly. MRIs don't tell you where pain comes from. They show structural abnormalities of the spine. They'll show a disc herniation. It doesn't mean that it's causing your pain. They'll show arthritis. It doesn't mean it's causing your pain. So the arthritis could be old. It could be over, so it's not causing pain. My point to you is simple. You will not change the opinions of the doctors and the medical community yourself. I can't even change it. And I publish papers on this subject. I show videos of patients cured of pain all the time, and yet my colleagues don't believe it. Doctors don't believe it. The community doesn't believe it. It's going to take years and years and years before people change the opinion about being able to cure back and neck pain. But right now we are doing it. We do it every day. We do it all the time. It's very easy to do and very safe. So my advice to you, if you're suffering, do a free teleconference with me. We offer free teleconferences via Skype to anyone in the world that wants to meet with me and talk about their back or neck or thoracic pain. If you do a teleconference with me, and the way you do this is you're going to want to go to the app and you're going to want to submit a questionnaire or a contact form, fill out your name, your phone number, your email, where you're having pain, is it in your back, your legs, pretty standard questions, and then request to do a teleconference with me. I'll do 15 minutes face-to-face with you, and we'll figure out where your pain's coming from, and then we could do an MRI here for you in Florida if you can travel here. We do have people that travel from Australia. We have people that travel from all over the world. So my best advice to you is come to Duke Spine Institute. Don't waste your time trying to convince your doctors. They're all going to think you're crazy, and they do that in America too. Unfortunately, it's common all over the world. These doctors are so stubborn to believe that there's actually a way to cure pain. It's becoming more and more doctors are starting to understand it, though. The ones especially that do the surgeries that cure pain, they see it because they see their patients after the surgery. They know they can cure the pain. There's not a lot of surgeons that can cure pain, though. Okay? I'm sorry I don't have a better answer. I hope you all enjoyed the surgery. We'll be back in 30 minutes to 45 minutes with the second surgery. This patient that comes to us travels from out of state. She's coming from Chicago? From Chicago. And she's actually the daughter of one of my former laser surgery patients, a nurse, who sent her daughter to us for the same problem. All right. Hope you enjoyed the surgery. We'll talk to you soon.